Welcome everyone in the first Pain in Motion Masterclass of 2023. We are very pleased that Dr. Hotz Boendermaker has agreed to give this Pain in Motion Masterclass. Sabina has a clinical and scientific background in physiotherapy, pain psychology, and neuroscience. That unique combination places her in a strategic and unique position to conduct research from practice to science. And therefore, it makes sense, of course, that she translates open clinical questions into research projects and contributes to the knowledge base in physiotherapy and health science. She's based in Switzerland, and she's a lecturer and a supervisor of several PhD candidates at the University of Applied Sciences in Winterthur in Switzerland. Today, she will talk about time point of adaptive brain changes in acute low back pain, and I think it relates to one of her recent publications that she did together with Bart Boendermaker, and it was published fairly recently in one of the Nature journals. So I will now give the floor to Sabina, and good luck to you, Sabina.
So good evening, everybody. Thank you, Jo, for the kind introduction and for the invitation to this masterclass. That's my work building, and I collaborate there with Bart Boendermaker, as you said, Fabian Pfeiffer, and from the University Hospital Roman Büchler and Lars Michels, and from the VUB with Iris Peters and Jo Nice. And the research is funded by the Swiss Science Foundation. So now let's start with the talk. You all know the biopsychosocial approach to treatment of low back pain. I have here the factors that can contribute to this model. And indeed, it is fairly complicated. Many factors like from the bio, from the psycho, the social side interact. I focus today on the anatomical and biomechanical factors from this model. So I ask you, what do you know about the lumbar spine's brain representation? When I discuss with colleagues, it's always very clear the representation of the lumbar spine is supposed to be very small. And this comes from the Wilder Penfield's homunculus and this picture we have in our mind. And if you look at the medial part, you see that the back is fairly small represented. And 8 decades after Penfield's discovery of the homunculus, there is still very sparse evidence on the representation besides the homunculus. Here we have the homunculus, and you see the proportions of the body. It's very clear for everyone that the hand with its many musculoskeletal structures has a huge representation. But given the size of the back in the homunculus, it should be function like a stick. But if you consider the musculoskeletal elements of the back, it cannot be that the back is so small represented. Below you see the 2-point discrimination, and you see here also from the skin that the back has a huge 2-point discrimination. It means it's not as good as the hand, and that confirms the size of the homunculus. I was looking for the neuroimaging evidence of the back in the brain. And when I started out, the Floor et al. Paper was still a sort of gold standard in this field. It resulted from painful electrical stimulation in the lower back. However, if you look on the representation, you see the control group in green and the patients in red. And from the perspective from the homunculus on the sensory representation, I always wondered why the representation of the patient is more in the location where you could expect it, at the center, but it was called a reorganization. Other studies tried to represent the back in the brain, and usually they took also sensory stimulation. That's just a latest version of an experiment also from Zurich, where they tried with vibration units to make a representation from the whole back. However, all these approaches do not directly tackle the lumbar spine. So about 6 years ago, we started out to design a paradigm to investigate the representation of the musculoskeletal system. For that, we took a functional spinal unit. You see here the parts of the functional spinal unit. There are bones, there are ligaments, there are capsules, and all these structures have huge mechanosensory efferents that are important for postural control. Now comes together my background as a physiotherapist and a neuroscientist, and I had the idea we could try posterior anterior movements, PAs, on the spine. And we decided to do a non-painful paradigm because we were interested in the functioning of the somatosensory system without painful stimulation. And we applied pressure on the first, the third, and the fifth spine. Because they have overlapping innervations, we took every other lumbar spine. And we controlled for pressure force by sensors. And below you see the paradigms. We had different locations, and the hand as a reference. And we had 5-second stimulations, and then an interstimulus that was jittered from 6 to 8 seconds. So the recording does not always start at the same location. Here you see the setup. In the middle, the most important, the Bart, who is doing all the stimulation. He is a manual therapist, and he just has the skills to do it. You will see it then in the recordings. For the stimulation, we had a projector in the room where Bart could see when he had to start and to stop the stimulation, and at what level. Then the patients had to be in prone position, so we could reach the back, and for that we used a special pillow, so the participants could breathe in the prone position. And on the right side you see the sensor that were attached to the back, and that they were very thin, and Bart could feel through the sensors the spinal, the bone of the spine. And here are the results from the primary sensory cortex. Just see on the left side below, you see the stimulation force, and you see how consistent Bart was applying his force. So When you look at these pictures, you see on the left side the spine, the first, the third, and the fifth lumbar vertebrae color-coded, and you see the representation of this of the spine in the primary somatosensory cortex. And you see that it's not a clear somatotopy, but they are very close together. And what we found was a very strong group activation for this PA pressure bilaterally in the primary somatosensory cortex, which is consistent with the homunculus, although the activation was much larger than you could see on the homunculus. There is an overlap between the vertebrae, no evidence for somatotopy. And what we found was very astonishing. Every single subject was within 1 millimeter on the representation. So it's a very strong and concise activation pattern we could apply here. But besides this representation in the primary somatosensory cortex, actually the whole brain was activated in regions that are responsible for perception, here in yellow, that are responsible for processing information and also for retaining. So by applying PAs on the back, it's not only a sensory effect you have in the brain, but you have a whole cascade of processes that are evolving. So the proprioceptive information that we can see here in the cerebellum, in the SMA and supplementary motor areas, and in the insular cortex, that represents the proprioceptive information, and that is mandatory for anticipatory postural adjustments and stabilization of the lumbar spine. So whenever you move, these brain areas are also active for the stabilization of the spine. So we have the idea that we actually can mimicking actual trunk movements while we can record brain activation. And of course, we tried this paradigm in chronic or in patients with persistent pain. They had pain for more than 6 months, and we applied the same paradigm. Here we investigated region of interest. That means you take only a part of the brain, and then you look on the representation. Actually, we did not find any differences in the primary somatosensory cortex, which is not uncommon for nociceptive pain. Reorganization in primary somatosensory cortex S1 is usually found in when you have other pain. And then we found a blurred representation in the secondary somatosensory cortex in S2, which was not, so we did find somatotopy in the controls, but that was not evident in the patients. You can see the blurred representation on the right side in the patient group, and you can see the somatotopic arrangement on the left side in the control persons, where you can differentiate between the three, the red, the yellow, and the green color. When we did look at the whole brain, there were only small differences in the activation patterns, mostly in the frontal cortices, which indicates that more than somatosensory processes are ongoing in these chronic pain patients. So to sum up, we have actually a downregulation of sensory motor processing in patients when they have persistent pain. That's common for non-painful stimulation. If you have a painful stimulation, usually you have an upregulation of this processing. And it seems that not the perception per se, but the evaluation of this input that is mandatory to introduce behavioral responses has changed. There is disturbed representation of the individual lumbar vertebrae and also for the integration of information. And also we found a decreased motor preparation. And it could affect the movement control, disturbance, potentially the body schema, and could reflect the non-selectivity in chronic pain states. So after we had this information from persistent pain, we were wondering when actually does a reorganization start? And that is very important also for the treatment, because if you have a very early reorganization processes, maybe then you have to approach patients with low back pain differently. So we decided to investigate the same paradigm, using the same paradigm in acute low back pain patients. And that's the publication you was just referring to initially. We investigated 18 healthy subjects as a control group and 17 patients with acute low back pain. And the pain duration was less than 4 weeks. They had an average pain intensity of 4.5, and the range was 2 to 8. The Oswestry Disability Index was low, and they had a moderate to high state anxiety score. So that indicates these were not that were actually common patients. We recruited them in our physiotherapy praxis. They did not have extensive pain, and they were not disabled by their pain. Now we applied a different analysis of for the fMRI experiment. You see on the left side, previously we had the analysis was single subject on the location, and then we computed a group activation. And by doing so, we did not find any changes in the acute patient group. So we applied a different approach. That was the functional connectivity, which is defined by the statistical association of 2 or more anatomical distinct time series or location. You see here on the left side, you have a red and a blue brain area, which have activation, and you see on the right side multicolored activations shown below. We used the psychosocial psychophysiological interaction, the PPI, and there you have a theory or hypothesis-driven selection of a seed voxel. So you decide from where you want to start to measure the correlation. And as we use the CON toolbox, that's a software to measure PPI, we used from the Harvard-Oxford Atlas the following networks: the Sensorimotor Networks, which has lateral and superior Sensorimotor Network seats, the Salience Networks with different seats, the Limbic and anterior hippocampal network, and the anterior and posterior cerebellar network. And you can see we used seat regions where we have found previously activation. So in our situation, we had this hypothesis-driven selection of the seat areas. So I go now through the different networks and I show you the findings, and I also describe briefly the networks and what it could mean, the results. So first we had the Sensorimotor Network, which seems to be the prime network for somatosensory stimulation. You see here on the left side in green the superior and the lateral parts of this network. There in yellow you see the light yellow, it's the superior, and darker one the lateral somatosensory networks. And you see below how the information is passing through the body into the brain. And as in the persistent pain situation, we did not find changes in the primary somatosensory cortex S1. As I said before, that's not uncommon. However, we did see here also alteration in S2 for long-ranging networks. Why do we not find changes in S1? You see below from Muro et al. An investigation where they looked at different representation of painful stimulation, the red activation patterns, and below in violet or pink, the activation of touch. And you see pain and touch are not different, are similarly in the representation. That means just when a sensory stimulation is getting painful, you might perceive it more stronger, but the actual representation, it's not much different. So the S1 is dynamic. It updates the body of the sensory input, but it has no storage of it, and it collects the input from different sensory origins. Then, if you look at the Salience Network, you see here on the left side also the various brain areas that are involved in the Salience Network, mainly insular cortices and cingulate cortices. And this network is important for the afferent mechanosensory information after it passes in S1 and or S2. It filters, and the information is filtered and amplified at multiple levels in the neural pathways. And then in the Salience Network, there has to be to make a decision. How important or how prominent is this stimulation or this what we perceive? Is it a deviation from expected has it emotional content? And what happened if we move and you get painful information into the Salience network? Then it's clear the painful information, it's a priority. But while we are moving and we perceive this nociceptive input, there is also in parallel, there is also the normal, the proprioceptive input. But as the Salience network has to decide which one he prioritizes, the winner takes it all, and non-important sensory information is suppressed. So while we move in a painful situation, pain is always is always prioritized, and the proprioception less. And by comparing the input from the somatosensory, the proprioceptive input, the Salience networks approaches also the working memory. So to see whether that is a well-known stimulation or situation, and then it can act accordingly. And as we did stimulate in a non-painful way, so the PAs were below pain threshold, this was not perceived in comparison to the controls as strong as the controls would perceive this proprioceptive information. You see here in the picture the seed region in red, and the connectivity with the plant temporalis, so the S2, and the operculum region in the Salience network, or the seed from the Salience network. And you see the strength of connectivity is significantly lower in the patient group. So it seems that low back pain is a very potent stimulus for adaptive sensorimotor control changes. If you look on the left side, you see a graph how sensory efferents enter the Salience network, and then the Salience network decides on the stimulus and proposes a motor efferent. So when during a certain movement or certain information, there is always the idea or the aim to protect the lumbar spine from further tissue damage. So for this protection, the transformation for the behavior has to be protective for the spine. And that could result in adaptive movement patterns such as co-contraction, muscular defense tension, or avoiding trunk movement dependent on the situation and the beliefs of the patient. And when it's repeated, it becomes a learning process. And this all happens within the first 4 weeks of an acute pain episode. So we have now been talking about the perception and the evaluation of the sensory input. But the Salience networks has also connectivities with the limbic and hippocampal networks. Here, in contrast to the other networks, we have enhanced activation or enhanced connectivity between regions from the hippocampus and cerebellum. And that could indicate a consolidation of this learning process or building up a pain memory. So if regularly we have this input in the Salience network, which is considered harmful, we have a learning process, and this is strongly facilitated by the cerebellum, which is influenced the formation of habit. And then for the consolidation, there are several strings which has to be orchestrated, and the encoding finally depends on various factors in the distributed brain networks, as you might know from memory processes. And what could be the motivation for these behavioral changes or these motor changes? By changing the behavior approach, maybe we can protect certain motor mechanisms and prevent a pain experience. And when we learn to move or to have less pain, then it's reinforced in the memories. And there is also a co-working between the hippocampus and the prefrontal cortices, which is a direct link to the Salience Network. So these are playing very close together. And finally, you know, the amygdala is the center of the fear representation. And we have previously shown that fear of movement or fear avoidance belief are actually represented in the amygdala. So within 4 weeks, we have all this processing of motor memory changes and implementation of new strategies in the brain. And although the philosophers say only through suffering do we learn, I didn't think he meant it in this way. So finally, we come to the last cerebral network. You see here also the cerebellum and the superior frontal gyrus, that's the SMA. The supplementary motor areas are also have less connectivity in acute pain patients during stimulation, and I have explained in the healthy person what that could implement. This is a strong connectivity that's mandatory for trunk movement control. And you can see here also the patients have less connectivity, so the movement, the trunk movement control is impaired by this decrease. So in conclusion, we have adaptive changes in large-scale networks, and these are within 4 weeks of an acute low back pain episode. I hope I could explain how this could facilitate the multiple consequences of acute low back pain, particularly when concerning anticipatory postural control. And I noticed also that we have similar findings in acute and in persistent low back pain. So time-wise, we can consider that such changes occur very, very early, much earlier than we thought previously. But we don't know whether these changes return to normal after the pain subsides. That we have not investigated so far. And this has implication for the therapeutic approaches, which was not part of the experiment. But if you consider your acute pain patients, maybe it gives you some ideas how to approach acute pain patients in the future. So I'm at the end of the presentation, and I would very much looking forward to answer your questions and also discuss on the implications for therapeutic approaches when I have so many professionals who could assist us in gaining ideas.
Thank you, Sabina. That was very clear and highly informative. The floor is open for questions. Anyone free to ask, anyone willing to ask questions? If you want, you can, of course, post them in the chat, or you can activate your microphone and also your camera if you want. Before questions are coming in from the audience, perhaps I can ask a first question. Well, and it's probably also a question that is directed not only to you, Sabine, but also to Bart, because for sure Bart is also working as a manual therapist, as a physiotherapist in your clinic. And that refers, of course, to the final part of your final slide, the clinical implications and what you do with this improved understanding of the adaptive brain changes in people with acute low back pain, and the fact that it occurs so soon in the trajectory. What do you do with it in the clinic?
So I don't treat patients anymore. Bart, can you?
Yeah, I can answer that to retry. What is important is that you heard that the pain memory learns by positive effects. So I don't like that the patients have pain in treatments. So first of all, I do always explanation how pain works. I try to avoid beliefs and pain behavior. So we try to stimulate them in normal movement. We try to find the impairments of movement in the treatment in the first couple of weeks. Try to work with where are the important impairments and try to improve that. So first of all, explain pain. You know your note for that. Try to move without pain. Try to stimulate the activation level, and then you're on the good road, I think. So that's my answer. 10 points for
Thank you.
Yeah.
And if I can follow up that one, would you then consider changing part of the pain education based on the exciting findings that the two of you now have from this study and also from the upcoming work that is already integrated partly in Sabine's presentation?
Yeah. We did a lot of other measurements. She didn't talk about it yet, but I think what's very important is we try to focus the last couple of years of pain avoiding, but there's also another group that are endurers, people don't listen to those effects of the brain changes. They go on. And that's a very important group, which is not so in the picture last years, but yeah, we found in our research also with the questionnaires that people are very active, maybe too active. You also see that. So yeah, it would be an important point to when you treat patients to try to focus on what is their activity level, and most of the time it's not avoiding, it's too much. And I don't mean by then structural damages or something like that, but you see the rewarding and the learning of the brain is what is the effect of your behavior. When the pain is consistent, you do too much. Yeah, there is not a good link between your behavior and the neuroadaptive adaptations. So I think that's important. Most of the people are doing too much and they're not avoiding.
which I come to you, Naziru, which is interesting because fear-avoidant beliefs are represented in the brain,
Sure.
but overactivity has not this emotional approach, and so it's more from the mechanical side.
Yeah.
It's very interesting.
Fascinating indeed. Naziru, you have a question or comment?
Hello, good evening.
Hello, we hear you.
Yeah, can you hear me?
Yes, perfect.
Thank you very much, Sabina, for the presentation. I joined from Nigeria.
Okay.
Yes, I have special interest in pen neuroscience education, and in previous systematic reviews, pen neuroscience education is not recommended to be a standalone treatment, and the best combinations are either manual therapy or exercises. So I don't know, maybe if you have maybe any explanation concerning the learning and the changes in the brain, if maybe I combine the pen neuroscience education with hands-on treatment, which has its impact in the stimulation, and maybe a hands-off treatment, because I want to know maybe which one will now yield more learning and effects so that maybe patients will benefit more. I hope the question makes sense.
The question makes sense. I don't know whether I can answer it with the result we have obtained. So what we could show is that mechanical stimulation with actually should not imply any emotions, did actually activate many areas in the brain which are involved in emotions. And maybe that could be an explanation why, and that it's not conscious. That there are unconscious processes in the brain, and maybe so by combining a hands-on approach and education, maybe you can consciously approach patients, and you can change this unconscious combination.
Yeah. Oh, it's an interesting answer. Thank you.
But we have not been looking at combinations or so, or treatment. Actually, that would be a nice follow-up to see
Yes.
different approaches. Now you give me some ideas. Different therapeutic approaches could change these reorganizational processes.
Maybe
Thank
I can
you.
very quickly. The goal of the whole research project is to understand why some people get chronification and why people are healed after 4 to 6 weeks. That's the primary goal. First, we have to understand what's happening in the acute phase, and then we try to improve the challenge to avoid the chronification of those patients. That's the main goal. So I don't think that the hands-on therapy or the exercising, yeah, you could adapt them now if you have that knowledge. But the most important thing is which factors are important to avoid that chronification. That is our main goal. And we did some analysis already. We will publish it in 1 to 2 months, the results after 3 months and after 5 months or the 6 months. And then we will see which factors are also involved in that chronification process and what's happening in the brain. Are there still changes, or I mean, that's the main goal. So I think exercise is always good. Manual therapy will help you when you have impairments in some structures in the lumbar spine. But the main thing is how to prevent the chronification. And that's a multimodal effect problem.
And that's why I think we should make more research in acute pain patients.
Yeah.
There's so much research in chronic pain patients, and it's always too late. we should try to prevent these chronifications. And I know there are some also economic reasons why you should not treat low back pain patients very early, but maybe by knowing that such reorganizational processing appear very early, maybe these stratifications with a STARP at SUS or so make sense to find out which patients are at risk for becoming chronic at a very early stage and not waiting until it's too late.
Yep.
I couldn't agree more. Any other questions from the live audience? There are no questions from the audience via microphone, nothing appearing anymore in the chat. There was somebody who was actually in the live meeting, but had to discontinue following it live, but we'll send, because she's sick, but we responded that she will actually be able to show the recording of this via our Pain in Motion YouTube channel. So if there are no additional questions or comments, then I think we have to give Sabina a big applause for her wonderful lecture.
Thank you.
So thanks a lot. You did very well. And thanks everyone for joining in, and have a nice evening.
Thank you. You too, Jo. See you soon.
Bye, everyone.
Bye-bye.